look from Dr. Alsy. So I'll be presenting on behalf of Medicine 4, the Cunning look-alike. So this is about Mrs. B, a 42-year-old lady, a housewife from Chittoor, who presented with easy fatigability for 2 months, loss of weight and loss of 1 month, breathing difficulty for 15 days, mild jaundice for a week, and fever for 1 day. History of presenting complaints. 2 months ago, she had easy fatigability associated with some breathlessness on exertion, NYHA class 2, on no history of chest pain, cough, palpitation, syncope, pedal edema, decreased urine output. She also had some non-quantifiable weight loss and appetite loss over 1 month. She also noticed to have mild jaundice 1 week ago by the relatives, but there was no history of generalized itching, dark-colored urine, or pale-colored stools. There was no history of any heavy menstrual bleeding. There was no history of blood in urine or stool, no history of decreased urine output or dark-colored urine, no history of fever preceding the onset of symptoms, no history of recent recurrent infections since childhood, no history of bleeding from any superficial cuts, joint bleeding, no history of joint pain with morning stiffness, skin rash, or any excessive hair loss. So she was seen elsewhere for the giddiness, was evaluated and found to have a HB of 5.1. So she was given iron supplements and was discharged 2 months ago. And 1 week back, when she developed her menstrual cycle, she started having the similar symptoms and fatigue, but the menstrual cycle was normal volume with no clots. She was evaluated for the same elsewhere and found to have anemia of 5.2 and a bilirubin of 3, and was transfused 1 unit of packed red cells. During transfusion, about 30 minutes, she had breathing difficulty, but there was no feature of anaphylaxis. There was no wheals, itching, noisy breathing, no swelling of lips or face. She was given IV steroids at that point of time, and she felt better and was discharged. And the next day, over the next 3 days, she noticed worsening of the jaundice, and her breathlessness persisted, for which she was brought to CMC. Now, past history wise, 2 to 3 years ago, she was treated with iron and vitamin B12 injections, and with documented history of anemia, after which her symptoms improved. There were no other known comorbidities, no past history of any bowel surgeries. Personal history, she had normal bowel and bladder habits, consumed a mixed diet. She is married and has 2 children, no history of recurrent pregnancy loss. Family history wise, mother had uterine malignancy and sister had breast cancer. Going on to the examination, she was alert and conscious, pulse rate regular, and all peripheral pulses were present. BP was 110/60, respiratory was 22 per minute, saturation was 94%, and she had a temperature of 101. GCS was 15/15. She was pale, she was ectric, her JVP was elevated. There was no sinus clubbing lymphadenopathy, but bilateral minimal pedal edema was there. Respiratory system examination, she had bilateral crepitations in the infrascapular areas. Rest of the systemic examination were unremarkable. So, summary: a 42-year-old housewife from Chittoor presented with dyspnea on exertion, NYHA class 2, with constitutional symptoms of easy fatigability, weight loss, with a recent history of blood transfusion outside, jaundice for a week, fever for a day, and examination found to have pallidus, features of heart failure with mild splenomegaly. So, what are the differentials you would think of? So, moving on to the differentials we considered. So it was anemia and failure with jaundice and hepatosplenomegaly. So this picture was suggestive of hemolytic anemia. We considered acute hemolytic transfusion reaction as the first differential because there was a history of transfusion was worsening of a jaundice. The second differential we considered was the autoimmune hemolytic anemia. Third was infections like malaria, and fourth was the thrombotic microangiopathy, and fifth would be metabolic causes like vitamin B12 deficiency. So her investigations, her hemoglobin at presentation was 4.8 gram per dl with the MCV of 125.4 and RDW of 29.4. Her platelets were 25,000. Total bilirubin was 7.75 with direct bilirubin of 2.77. Our SGOT was elevated 519, LDH was 5,326, peripheral smear retics were 5.05 but corrected was only 1.7. Her peripheral smear showed a dimorphic picture of hypersegmented neutrophils as well as anisopoikilocytes. Vitamin B12 was 100. Pernicious anemia, antiparietal cell antibody was positive. DCT was 2 plus, but ICT was negative. Her monospecific DAT showed IgG positive with CD3, C3D positive, but her cold agglutinin titers were negative. And CRP was elevated 62.5. Her C3C4 levels were low. C3C was only 41.6 and C4 was less than 5.43. Ferritin levels were high, 8,753. And urine routine had showed blood 2 plus and hemoglobinuria was present, but her PNH workup was negative. Bone marrow biopsy, the smear showed severe megaloblastic anemia, but bone marrow biopsy was normal. Malarial parasites were negative. Schistocytes were 0.4%, and Adams TS13 was normal. Ultrasound abdomen had showed borderline splenomegaly. So coming to our patient, based on the investigations and the history, we considered the anemia was multifactorial. The first thing was the anemia was multifactorial. The first thing was the pernicious anemia because the peripheral smear had showed hypersegmented neutrophils. Her vitamin B12 levels were low and antiparietal antibody was positive, and this marrow showed a severe megaloblastic anemia. Definitely vitamin B12 deficiency with pernicious anemia. So the second was there was direct hyperbilirubinemia with elevated LDH. DCT was 2 positive, but ICT was negative. But again, monospecific DACT showed IgG and CD3 positive. So the possibilities we considered were transfusion reaction. Second was autoimmune hemolytic anemia with cold agglutinins. And third was paroxysmal nocturnal hemoglobinuria. Now, her cold agglutinin titers were negative, PNH panel was negative, and ANA was negative. So, in view of no history of hemolytic crisis in the past, she was considered to be a case of pernicious anemia with probable hemolytic transfusion reaction. So, here the high levels of LDH and ferritin were markers of severe hemolysis, and isolated vitamin B12 hemolysis will not cause a hypocomplement anemia. That's why we thought it was a acute hemolytic reaction, acute transfusion reaction. So I'll be talking about acute hemolytic transfusion reaction. It refers to a transfusion associated hemolysis that occurs during the transfusion or within the first 24 hours of transfusion. It is an emergency and it requires immediate cessation of transfusion. So pathophysiology, the most common pathophysiology associated is ABO incompatibility. And AB incompatibility, it is most often the result of a clerical or a procedural error, like the blood sample has been wrongly matched or in a the wrong tube has been processed for the same patient. Or it could, in small proportion of cases, there can be minor alloantigens, those with blood groups of Kell, Duff, or J blood groups. Now, pathophysiology wise, there is binding of antigen. The antigen antibody binding will result in the activation of complement cascade as well as phagocytosis. So, these activated macrophages will lead to the production of pro-inflammatory cytokines, and that can elicit a systemic response like fever. So it could be extravascular or intravascular. Extravascular is usually by activation of reticuloendothelial system, and intravascular is by complement activation. So role of complement intravascular hemolysis. So the alloantigen in the heme in the alloantigen, RBC antigen will activate the complement system. And once the complement system is activated, the membrane attack complex is formed, which causes holes in the thus releasing heme into the bloodstream, and thereby there will be consumption of complements. Okay, so symptoms would be back pain, flank pain, fever, chills, hypertension, evidence of DIC, hematuria, oliguria. Lab-wise, they can have decreased fibrinogen, globin, elevated bilirubin, elevated LDH, hemoglobinuria, spherocytes on the peripheral smear. Otherwise, documentation of either immuno-mediated or non-immune mediated hemolysis require a positive DAT with a IgG or an anti-C3 positive, or non-immune would be a serological negative, serological testing negative. So management would be, if to stop the transfusion, provide hemodynamic support, distinguish the possible causes, and stabilize the patient, and consider other differentials of hemolytic anemia also. So in our patient, she was given 4 days of dexamethasone pulse in view of severe hemolysis. However, we stopped once there was severe hypercomplementemia and hemoglobinuria. She improved over the course of hospital stay, and her HB improved from 4.8 to 8.9. She was discharged on injection vitamin B12 and folic acid. So the learning point are if minor allobody present, there can still be ICT negative. We can still call it the low titers of DCT positivity is enough to have a clinical suspicion of transfusion reaction. ICT can be negative because minor allo antibodies might not give you ICT positivity.
Thank you, Dr. Alsy. Are there any questions or comments from the audience? Often